I think most of us born in the United States and Canada realized that when we were born, we won the lottery because we were born where we were. And having won that lottery, we feel like this is a payback. We've got a lot, it's good to give something back in return.
How do you feel that you don't pass it?
I don't want to overemphasize. We're not trying to sacrifice. We're not giving up a lot with what we do. For most of us, this is not a painful experience. It's not an ordeal, but it is this an opportunity to give back.
Philippines, it's about what I expected. I think, of course, the hospital is over 100 years old, and you know it's been updated here and there, but it's not quite what you would see in the United States.
My first impression of the hospital was, it's actually kind of funny. I lived in England for a little bit, and I used to think that their hallways looked a little bit run down, you know, being kind of a first world country, but walking down these hallways as well, yeah, they might be a little bit run down, but they're very functional. The same concepts, the same principles apply. There's, you know, hemodialysis. They have the machines that they need. They might not be up to par with North American standards, but they work.
I thought it was going to be not as densely populated, like nowhere near. I thought there was going to be very, very rural, but it's very populated. Apparently it's supposed to be for 300,000 people, and there's over 1 million people here. The traffic is crazy, and the pollution is something I really didn't expect.
It's overcrowded now, lots of cars, and there's some pollution now in Baguio. Not like when we were young, it was so nice, then lots of pine trees all over. But now with the pollution, some of the trees, they're dying.
This hospital is about almost 400 capacity. It works on 30% paying patients and 70% indigent, or to the poor people. One of their mission values is focus on teaching, training doctors, training nurses, and of course they are very grateful that we bring a lot of surgical equipment and medical supplies to support this program.
My name is Robert Pinlat, and my job in the organization is I'm an interpreter, and I'm the gopher, like go for this and go for that.
You speak English?
I can speak about 3 or 4 dialects, so when they interview these patients, I can speak those languages, so it's easier for the doctors to catch up with the patients. They get these patients from different places. They advertise it in the newspaper, on the TV, and through the doctors who met these people who are indigent. So they recommend them to come over at the outpatient, and that's where they go.
Before we come for our mission, they have already done most of our pre-admission. For example, they pre-admit our patient coming from the mountains. We also cater to the people from the lowlands, which is Pangasinan, and also the Ilocos region. So the local people who are from the different kinds of health centers, like a community health center, they gather up all these patients from different locations of the Philippines, and they see what kind of procedures they need. And the social worker also comes into place by interviewing this patient that they are really poor. It's not only us doing the work, but all different areas.
See how easy it is to cut? See how sharpened it is? Yes, if there's no tension, you cut. So put tension on and you cut. If you compare resins here and the North American resins, I think that education-wise, standard-wise, they are fairly equivalent. But I think that their training is geared towards local disease processes, and they would do very well if they stayed here, but they would not do very well if they went to North America. And likewise, the North American resident would not do very well here. Remember Mary's ligament?
Yes, sir.
So this is the nerve here. So you want to be dissecting anterior. The spectrum they cover is wider. So we are sort of more narrowly trained. Yet we are trained better in what we do, but we don't cover a wide area. That's why if you have surgeons that come to missions, I don't think young surgeons should come. You should have experienced surgeons so that they can tackle more things, because oftentimes you are expected to do things that are outside your comfort zone. You are not just going to do hernias and gallbladders and stuff. You will be expected to do a little beyond what you normally do.
I can teach things they don't learn here. It's not that they learn bad things, but there's always alternative techniques. 3 or 4 years ago, I was in Vietnam, and I was assisting on a surgery, the kind of surgery I've been doing here, and I saw them use a technique I'd not seen before. I said, wow, that's a good idea. And so I started using it back home. My surgical assistant saw it, liked it, told one of my partners when he was doing surgery, and he's doing it now too. So you have this cross-cultural exchange. There's no who's better or who needs help. It's just everybody does things a little bit differently. And so when we spread the culture around, or spread the information around, it's very good. So the residents are seeing me use techniques they'd not seen before.
What is this?
Sticky rice?
It's like a rice cake?
It's a rice cake. It's just that they grind the rice.
Yeah.
It's kind of like that thing in the banana leaf yesterday.
You have to dip it. You dip it on that dinuguan. So
This is sweet?
it's so good.
I don't know, put that in there.
It's really good. So what's in it? Chocolate meat.
I'm part Chinese myself, so I always find it really nice to get in touch with that Asian side of myself. It's kind of nice here. I'm not used to working and having somebody prepare my lunch for me every day, and it's not always to my liking or to my taste, but I'm always willing to try. And today I was so lucky to indulge in this dish that tasted so yummy, and when I was done I was told that it was actually meat cooked in blood. But that's okay, it's nice to try it. When I lived in England, I knew black pudding was deep fried blood, and I missed out on that experience, so I'm really glad that I got to try this authentic food, and I'll continue to try it as long as I can.
One of the things that I've found really interesting is coming here and learning from the local nurses how to adapt to not having as much equipment as we have at home and not having the same situations. It can be really difficult.
I think you can't just come to a hospital and change everything, because that's great that we do it back in Canada, but here they're limited to their resources, so you just got to make do what you have and try to do as best as you can.
The pace is a lot different. It's a lot more of a relaxed environment. The equipment's a lot different, and sometimes patients don't speak a lot of English, so you have to take your time with them and make sure they fully understand what's happening.
In the States, we don't have the kind of time that we would have here. It's all about how many cases can you get in a day in the States. Here it's what can we do for this one particular patient. So I kind of like that.
The more cross-pollination we can get done, the more different viewpoints, different ways to get done things we see, the better off we are and the better tools we have to offer our patients.
When I first came, it was really interesting because we tend, in North America, we tend to provide a lot of privacy for the patients. Like we'll put screens on the door so that when they have their legs up in lithotomy position, there is a privacy. Here, there is a window across the front of the OR, and you have all the student nurses watching everything. It's a culture that is not, to me, I don't think are shy. That surprised me at first, was that all of the people looking at this woman's V-zone, they call it. They call it the V-zone here. I saw that in the supermarket.
So now, take the cautery.
Our first patient was quite a difficult patient. It ended up taking 8 hours. We needed blood for the patient. I asked Shirley how we get blood, and she says that sometimes the family member has to donate blood. So I found that like, wow, here we have to go find a family member, take blood, and then process it to the patient.
She's having lots of pain, and even when she turns around, you know, she has a pain in her side, there's difficulty of when she breathes, and didn't give her the pills postal. None of our patients were given pain medication during the night, so all of them suffered, and then they said they cannot anymore. So today,
she's complaining actually about the Foley catheter. It will be taken out when? About a couple more days?
No, today.
Today?
Yeah.
So they will.
So she had a TAH for this endometrioma. So the surgery went well yesterday. Now we were a little worried about it being cancer, but no cancer. Okay, good. So are you taking pain pills okay?
Yesterday.
Excuse me?
Yesterday.
But during the night?
Yesterday evening.
You should take some pain pills every 6 hours. And the nurses are supposed to give them to you. If you don't get them every 6 hours, ask for them because it's important.
There's one nurse and there's 80 patients. And back home, we have one nurse for 5 patients. Granted, they've got about 18 student nurses that are working with them, so they've got those, you know, but just depends like what stage they're at, how much they can do. So this one nurse has to look after this 80 patients.
They're very, very understaffed, and they make maybe $17 a day for a 12-hour shift. And but a lot of them work for free just to get experience. They're very, very good nurses, and I just find it sad that they do their 4 years of training and there is no work for them.
I went into nursing in 1965 and then finished school in 1968. In the Philippines, when I was a student, we used to boil needles to sterilize them and then inject patients with it, and you can hear them like sort of like cracking noise on it because it's so dull. And then I remember that we used pots, you know, like to boil them in a kettle. My friends and myself were saying like, you know, oh my gosh, I don't want to be, you know, getting a needle from, you know, the needles that have been, but because the hospital is so poor, we have to use them over and over again till they break. That's one thing. And then mattresses in there were so like, you know, even no matter how people try and clean it up, we saw that how filthy the hospital is because they didn't have any money to change beds or linens and mattresses. So sometimes mattresses are with holes and sometimes dirt and blood seep into it. And of course, when I came to Northern America, which is the first things I went to Canada, it was much, much better. And I keep thinking, you know, oh my gosh, you know, I mean, I wish we had these kind of hospitals from Canada back in the Philippines. She's so hungry. So what can she eat?
Well, same thing. Same thing. Start off with liquids.
Okay.
And then if she tolerates the liquids, like you said, a soft diet in the afternoon.
Okay. Okay, ganito ang gagawin natin, ano? Kasi hindi ka pa pwedeng kumain ng marami. Unang-una, kung may lugaw sila rito, lugaw ka muna. Saka kung marami kang gatas o juice o kahit ng kami ng tubig. Pag malakas-lakas ka na, maglalakad ka ng okay, mamito siya. Okay, hinikat natin yan, diamatres mo, dakkel, nakapagkat. lots of adhesions behind.
But we didn't find a fibroid.
Okay.
I think we found cancer of the uterus.
Okay. Nga dige bukol-bukol tinabirukan dati panagarot dito yung doktor adati ko ang cancer mo. Okay.
Now the good news is that I think the cancer's all gone because we took it all out.
Okay, so pati panagarot na di cancer mo napukawan ta na ikabig igya may matres mo. So that is the good
That's
news.
good. However, just to be careful, we may want to give you medicines that we call chemotherapy in a few weeks or a few months to make sure that it's all gone.
Okay, nawatan mo yan. Kasi ko, may hospital dito, in the hospital, I think they have chemotherapy. Chemotherapy, tapos lang yung aginom ka ting agas, adati ko, with any radiation, no, just chemotherapy.
I think it's just chemotherapy.
Okay, chemotherapy. So nga, the Dr. Igama, he's specialist on this cancer stuff, right? So we will ask Dr. Igama to talk to you about it. If it's covered by your insurance, no, that insurance, yung nung indigent kayo, then it will be libre. Indigent? Yeah, okay.
Now, I'm saying this is what I think I saw. There'll be a final report in a few more days that will tell us for sure.
So tata, the specimen, right?
Yeah, I always worry about complications. We had a first case. Unfortunately, we discovered that she had undiagnosed cancer. We thought it was a benign condition based on ultrasound findings. The ultrasound was not accurate, which happened yesterday as well. So her big issue is going to be coming up with the money to pay for chemotherapy, which will be $600 or $700, but that may be more than she can afford and may not be able to find it through the hospital at all. So that's her big issue. But I think the lesson in this case maybe is to say, wow, this is a difficult case. We have unexpected cancer. We have some cancer means there's more likelihood of bleeding, scar tissue that's hard to distinguish between different tissues and organs in the body. And so I think sometimes we need just to pause. It may not seem like a long time, but 30 seconds, a minute, and just step back and say, okay, this is where we are, this is what we found, and this is the challenge. How can we deal with it? And that learning to calm down and step back is probably my biggest lesson.
Anesthesia is life support. It's a crucial part of being able to provide for safe surgery. Working in a place like this is like stepping back in time a few decades. They still use halothane here, which is a drug that my younger colleague has never used. We're spending a lot of time looking through boxes full of cables and trying to find the right connectors to get every piece to work together. There are a lot of cables that can get frayed and broken, and you can't find replacements for these things. This time we checked all our equipment, plugged everything in, and you have to make sure that you plugged in the right equipment to the right voltage, since the Philippines runs on 220 voltage. We got our anesthesia machine plugged in, turned it on, and all of a sudden it started to smell like something was burning. In fact, nurses from the hallway ran in to see if something was on fire. It turned out that the machine was just warming up and it seemed to be working fine.
You guys have to be very careful when you're plugging in the converter and really check. Make sure if it's 220 or 110, because our machine's gone. Like ventilator, they're going to try and fix it. The electrician's going to come. That's what happened to also the CO2 machine, because we just talked to the electrician today to check the machine. Today, Shauna, Lisa, and Jane will be leaving early, so as soon as the gynae room is done.
I came to Canada when I was 11, and even though I grew up there, Philippines has always been in my heart. I grew up in a very, basically in a squatter area too, and I know what it's like not have anything. So I really appreciate everyone that's come here and help all these people, because I still have family who are in very much need here in the Philippines. So every single one here are very special to me to be able to help my people. I feel very fortunate to have grown up in Canada and always thought in the back of my head that hopefully one day I'll be able to give back to the people who are in need. And I'm just so happy to have this this career that I can do that, and so many people are willing to help, not just in the Philippines but all over the world.
What is this?
This is a song.
What for?
For the grand appreciation dinner performance.
When is that, tomorrow night?
Yeah.
So then, when you approach your patient, they will say, "Masakit ka ba?"
Masakit.
Masakit. So, masyo. Masakit ka ba?
Masakit ka ba?
Masakit ka ba?
Masakit ka ba?
Nalpasan ti operasyon nyo. Nalpasan ti operasyon nyo. Okay? And then, and yet this is wrong.
Tagalog. It's mixed Tagalog.
Who gave you this?
The three of us. I know it's mixed. Because in Baguio we're mixed anyway.
Alright. Okay, and then you go say, umangus ka, sige pay, sige pay, sige pay, sige pay. You know, so, meaning you're breathing more, like, you know, have more breath, right? And then the next one is like, it's about farting, right? If he has passed gas already. So, umutut ka na ba? Umutut ka na ba? Umutut ka na ba? Tumahi ka na ba? Tumahi ka na ba? Tumahi ka na ba? Sige pay, sige pay, sige pay.
We need a dance.
Yeah,
like this. Sige pay, sige pay, sige pay.
You don't do it like this because you're so suggestive. I think you go sideways.
3, 2, 1.
Napasa diagra, napasa diagra, napasa diagra. Sige pay, sige pay, sige pay. Umanos ka, umanos ka, umanos ka. Sige pay, sige pay, sige pay.
No, it's perfect. Looks good. Not too much swelling. It looks very good. Okay.
And I have some cough.
Cough?
It's pain when I have cough.
That may be irritation from the breathing tube. That should get better within several days, okay? Yes, you had a hernia in the middle. We fixed a hernia for you on the top of your old incision. So the binders to take some pressure off it, okay? So I know that it hurts, especially because you had a hernia fixed. But it's important to breathe deep even though it hurts. Breathe deep so you don't get a collapsed, soggy lung, okay? Make sure you take plenty of fluid so you don't get too dizzy there, okay? Plenty of water, okay? Okay. You look terrific. Your numbers look good too. Thank you. Okay. Have you tried drinking, eating anything yet? Are you passing any gas? Good. Have you walked around a little bit? Good. You're doing wonderful. Look at her numbers. I usually leave them for 2 days. I'll take the dressings off. I think we'll have the anesthesia doctor just look at you here one more time, make sure everything is okay, and then probably can go home today. Okay? You've been here long enough. Waiting. Okay. The people here in Baguio City have been amazing to work with, and grateful to interact with us and to have the assistance that we provide, both from a medical expertise standpoint and from an education and teaching standpoint too. And they really seem to have a thirst for that, and they really appreciate it when we take the time out to do that. So that's in of itself its own sort of additional reward on top of the patients that we get to directly help with medical care. And that part's been, for me, a constant from other missions I've served, that the patients that we serve and the patients we help, and their appreciation for that is incredibly refreshing in the context of your daily medical life in the States, or I'd imagine in Canada as well.
We got some letters back today from some of the patients, and they're actually really, really sweet, and I guess as nurses and as staff, we don't necessarily hear how thankful that people usually are. And there was one lady who said that she'll remember us for the rest of her life. So hearing things like that is really sweet, and it kind of reminds you why we're here and also why we do the jobs that we do.
To GOMED doctors and staff, we are grateful that you came to our country to help our people like us. Thank you very much for the successful operation, to all the help you have given us. Hope you come back again. To the GOMED Surgical Mission, thank you for having my successful operation. I'm proud of all of you that you shared your blessing. I pray all you that you have a successful duration. I don't know this. God bless and more bounty to you all. Makalimutan ng GOMED team ninyo. Ang lahat, all of us are very good at makakaikaso sa pasyenteng bihira lang makagawa. Wala, this is difficult to translate now. Lahat kayo, we are all good and we are all compassionate and we tender to their needs or something like that. The rest I cannot.
She's the one, the real small person with a little butch haircut on this.
These are all your love letters, and I think we will all give it to GOMED. But I like the most is Dr. Rhoda here.
Yes,
you know?
Dr.
She photocopied this, and I said I'm gonna put it in the wall, and I need the raise from my chief.
Today I'm in gynae surgery, which I really like. The added case today will be a tubal ligation. The women can, as I said before, I think, can only have a tubal after they have their 5th pregnancy. So this woman is coming in, she's breastfeeding her last baby and coming in. They're not allowed to have birth control. Condoms are very, very expensive. So it's really difficult. There are so many people here. But having said that, they are happy. I really see that. On the bus to the resort that we went to on the weekend, one of the young gals from Vancouver said, "Oh, that's so sad," when she saw their housing. And I thought, I saw these people, the children, playing and laughing and running around and playing basketball. Basketball seems very popular here. And young men holding their wee babies and having their wee toddlers alongside them. And just that love and family. Just everybody seems really happy. They don't have maybe all the comforts and things that we have in North America, but that's okay.
Perfect, thanks. Okay.
I'm working in the field, planting strawberries, planting lettuce, removing the weeds from the, that's my work. But in April this one, I am very tired, so I stopped. I cannot work. I work just only a little and I feel tired. Because I'm very scared, but I said, God will help me.
It's amazing to see the patients and how happy they are to be being a patient. It's quite different than back home when they're walking into the OR. You know, they're excited rather than nervous.
You just feel so good and so rewarded seeing everyone's face after you give them what's basically giving them another life.
You think that if we took all of the money that all of the volunteers spend for travel and lodging and just everything to get here, and we could take that money instead and pool it and just give it to the hospital to take care of these patients, then that money could be used to buy suture, to buy drugs, and to pay local doctors. The doctors here work just fine, they're qualified, that they could do the same thing. And so you think, why don't we just do that? Well, there are a couple of reasons. Number one, the doctors here may not be as busy as may not have as much time as we think they have to do this. So even if the care was all paid for, there still might not be enough doctors to go around. I'm not sure of that. But also because, quite frankly, people are willing to give money to volunteer, just to give money to give to a hospital, an unknown, strange hospital they never heard of in the Philippines, they're probably not going to do that. So, so I think missions work, even though some critics might say, well, it would be better just to give money and let people do it themselves. I don't think that would happen. It's just not realistic.
Most of my volunteers come back because why they have that fulfillment. You know, like myself, why do I do this? Because every time I do a mission, I am fulfilled because I'm able to help people that cannot even thank me. I don't even know them personally. So by doing this, I know that there's a lot of people that we made them happy. Why? Because they're able to get back to better health, and by having better health, they're able to work for their children and themselves.
I'm going to be doing missions as long as I can. It's such a wonderful feeling to do it, and it's a lot of work getting it all prepared and getting ready and getting your family ready, but it's so worth it.
I just totally loved this whole experience. It's the most rewarding thing I've ever been on.
It kind of brings everyone closer, and now you're like a family. We have such a wonderful team, and as a first-time coordinator, I can't ask for any more. It's been such a great and wonderful experience, and I will always treasure this for the rest of my life.